because we know from the prevalent studies and cross-sectional studies that those who engage in more physical activity or less sedentary, they are at low risk of especially depression. I'm not saying it's a magic pill. Exercise is not a magic pill, and I don't want to sell it in that way. But if you think about what we provide as biopsychosocial tools, it's probably one of the best that we have. And for 99% of the population, it's really helpful, and we're always going to advocate for that. Small percentage-wise, there are some people who have exercise addiction, or orthorexia as we call it, this obsession with being healthy. So I often see that different spectrum as well, often on the inpatient wards. I'm quite lucky that I see different aspects of the spectrum when it comes to mental well-being through to severe mental illness.
You have found the Thinking Mind podcast. Hello everyone, welcome back to the podcast. This week it's Anya, and I am very excited to bring you a conversation with Dr. Amit Mistry. Dr. Mistry is a consultant sports psychiatrist with specialism in eating disorders and athlete mental health. He's the chair of the Royal College of Psychiatrists Sports and Exercise Group, as well as being the mental health advisor to Oxford University Sport and the consultant sports psychiatrist to the English Cricket Board Women's 11 national side. He is also the editor of the book Case Studies in Sports Psychiatry. I hope you enjoy. So, hello, Dr. Amit Mistry. Thank you so much for coming to join us on the podcast today.
No problem. Good morning.
Dr. Mistry, it's such a pleasure to welcome you. You work as a consultant psychiatrist, and you're also a sports psychiatrist, including for university teams, England sports teams. You lead the Royal College of Psychiatrists Sports and Exercise Group. So I'm really, really excited to hear from you about this area of psychiatry that actually I know very, very little about, but I really wish that I knew more, because I think it is something that we can get a lot from at a general population level, but also obviously it's something that is really important for our elite sports people. So what I really hope we can do is, go through a journey right through that. So right through what sports and what the impact of sports can be on our mental health at a general population level, but also be thinking about what sports psychiatry does for the elite sports people in the world. So I guess to start us off, I wonder if I could go right back to the beginning and ask you a bit and understand with you how you came to be interested in this area, what your journey to it has been like, and also just what a day in your work life looks like.
I think firstly, I was really fortunate as a kid to be involved with sport, so different team sports, and something that I really enjoyed, and I was always encouraged to do that. So from an early age, I've seen the benefits of that. And then getting into psychiatry, similar to your stage as a core trainee, in CT3, I took some time out. So I was playing rugby in Australia, got back, and at the same time, there's this explosion of a evidence base of the benefits of exercise for not just mental health, but severe mental illness. So it would have been around 2015, 2016. And I was really passionate about it. I was really excited. And then when I did my special interest day, so essentially we get one day a week to really focus on an interest or research piece. And for me, it was exercise for severe mental illness. So I was given an opportunity to work with Public Health England, and I was put in charge of their exercise promotion for severe mental illness. So already by doing that, I was exposed to other psychiatrists, other clinicians who were also passionate about this area. And fortunately for me, I was very, very lucky that the Royal College of Psychiatrists also set up the Sport and Exercise Psychiatry Special Interest Group. So again, similar timings around 2015, 2016. And again, my network grew. So I was around people who were really keen to promote exercise for mental health. And coincidentally, by being part of this, I was also working with kind of mentors who were already growing sports psychiatry, already quite established in sports. I managed to learn a lot about elite sport mental health versus the benefits of exercise. So I got quite a kind of well-rounded experience. And then over time, just organically, just globally, there's been interest in managing severe mental illness in elite sports, whether it's in Australia, America, for example. And a key time point would be 2018, 2019. So the British Journal of Sports Medicine did 2 papers on consensus in mental health in elite athletes. So it really gave you a snapshot of some of the typical mental health problems that we see in sport and how psychiatry can help in that. And then I was quite inspired by that. And I felt, well, actually, we've got this growing evidence base, but how do we apply that on a practical level? So myself, Professor Alan Curry, and a colleague called Dr. Thomas McCabe, we published a book called Case Studies in Sports Psychiatry. And what we did was we did 10 chapters looking at how mental illness presents in different sports. But what we did that we felt was quite important was we embedded an athlete in each chapter as well. So we've got the athlete perspective in terms of this is what I experienced, or this is what I've seen. And then we did that into a kind of a case study book. And then that same year, I was elected chair of RCPsych. For people that don't know what CPsych is, it's a nationwide network of psychiatrists and allied healthcare professionals with a twofold aim, really, essentially looking to promote lifestyle interventions for severe mental illness, but also thinking about the other side, which is elite athlete mental health. And then through that, I've also been working with the England cricket team, like you mentioned before. So I work for the women's team, thinking about mental health support for their athletes. And I also do a bit of work for ASICS Europe. So that's my journey, how I've got into that. And it's a real privilege to be part of it and seeing how this is expanding, on both sides, whether that's elite athlete or us as psychiatrists promoting physical activity.
That's amazing. And I guess how it all started as well, that work with Public Health England in terms of, I think you said, promoting physical activity and severe mental illness. It sounds so important. I'd love to hear more about, I guess, how that started, how you got thinking about it. What is it that sports can do for people with severe mental illness, and also just what we should be thinking about as psychiatrists or as clinicians working with people with severe mental illness.
I think there's something really validating as a clinician, being able to sit with somebody in clinic and say, tell me about your hobbies, tell me about your interests, let's talk about physical activity. And I'm very mindful of not talking about sport the whole time, because for some people it just doesn't apply. But around that CT3 period, I was working in an outpatient clinic. It was a general adult CMHT type setup. And you're seeing people in clinic, and I think patients really valued you sitting there and actually caring enough to say, look, tell me about your hobbies, tell me about your interests, and really simple things. And a really powerful resource, which I'd be really keen to share today, is something called Moving Medicine. So it's movingmedicine.ac.uk. It's a free resource for all clinicians. And say if you've got 2 minutes, 5 minutes, 10 minutes with a patient, it's a very practical, motivational interviewing type website where you say, look, let's go through physical activity. What do you like doing? Like they were saying, there's an activity for everyone. It's just finding what people like doing. I'm not saying it's a magic pill. Exercise is not a magic pill, and I don't want to sell it in that way. But if you think about what we provide as biopsychosocial tools, it's probably one of the best that we have. So from my perspective, using that in clinic and then being part of that bigger picture was really powerful.
Is physical activity, I know you said it's not a magic bullet, is it something that's sort of always a good idea, promoting some kind of physical activity or sport for people who might be experiencing either problems with their mental health or not experiencing problems with mental health but want to improve their well-being? Is that an easy win?
Yeah, I think the big challenge is, even as a kind of societal level, just managing sedentary behaviour, because we know from the prevalent studies and cross-sectional studies that those who engage in more physical activity or less sedentary, they are at low risk of especially depression. Anxiety, the evidence base isn't as established, but conditions like depression, we know it can be really powerful. And if we think about sedentary behaviour, that's doing less than 30 minutes of physical activity a week. So even we know that the ones who do the least amount of activity have the most to gain. So I think we really need to support people. And if we think about severe mental illness and people who have that, they have a lot of inequalities. They don't have access to the same types of facilities. They may have low motivation, obesity, these types of things. If we're going to support people to do this, we have to do that sensitively. We have to tailor it to their needs as well. And that's why I say it's not a magic pill. We've got to be realistic and we've got to be fair. But I think there's a lot to gain for people who don't have access to that.
And I'm so glad that you shared that resource, and we'll link to it in the show notes as well. Is there anything else from your work when you were even a core trainee, at sort of a really junior level? Was there anything that you'd kind of suggest to people is good to think about trying to incorporate into their work? Something that doesn't require like a huge overhaul of the entire inpatient psychiatric system, or something that actually is doable without a huge investment of money from like the government or people who might not want to give us any money.
Yeah, I think trainees, I think sometimes we forget how influential they can be on a local level. So whether that's arranging a local park run or just activity for patients in the wards, I don't see why not. That was something that, I was certainly able to do. And I've seen trainees within sport and exercise psychiatry group doing that as well. So I think if you've got a passion, you could do it as a quality improvement project. You could do it as a formalized project, so to speak. But in principle, with such a growing established evidence base, I don't see why a trainee can't do that. The best thing that happened for me, and I say this to everybody when I do these types of things, is if you're a psychiatrist in training, your specialist training, you have this one day a week to really focus on your passion. So if you're really interested in that, there's no reason why you can't do what I did, which is approaching Public Health England and saying, look, I'm really motivated to do this. And also it's a free pair of hands. You're not getting paid for this. You've got to follow it because you're interested in it. But if you are interested in that, there's a lot of value you can add to that.
What kinds of things within the, I'm going to get it wrong, the SEPSIG
that's
group?
Right.
Yeah. What kind of things are you looking at, or when with that side of your work that's promoting physical activity and severe mental illness, what are the kinds of things that you're interested in as a group?
So there's two names I should mention. So Claire Gilveray is our exercise lead. She's recently started that, and she does something called cognitive sports therapy. So that's her own business. But what's really inspiring about that is it's based on the 6 lifestyle medicine principles. I'm not going to try and do it off the top of my head because I'll forget the 6, but essentially it's, exercise, nutrition, sleep, stress reduction, all these types of things. And she's given really good examples of what she does on a day-to-day basis with her patients. The second name is Jennifer Keel, and she's our trainee lead. So they're doing lots of kind of initiatives as trainees to say, look, how do we promote this on a practical local level? So that's why I always encourage trainees on the call to get involved, because it's really good finding your network and knowing, well, if you've done this, how do I do that? And how do I kind of bring that to my local level? Examples of this, whether it's daily walks for patients, something really simple like that, or doing park runs. Some good examples I've heard of is even forensic mental health settings, people doing park runs, even in prison. So, it should be accessible to all. So I guess it's, these simple things that we can do on a local level. And then when we have national events, we all share this information. So how do I bring this forward myself?
And that's something that seems to be coming across as you talk, that importance of a network, or of doing these things not in isolation, but how for you it seemed to be important to have mentors and people around you, that you really conveyed that.
Absolutely. Crucial. I think especially as a junior, I was really privileged that I was offered that just organically through SEPSIG. I saw how people do that. So I think another thing I'd add to that is don't be shy to approach people. If you've got an interest or a project or a passion, just speak to people, and more often than not, you'll find people that are really keen to support you.
And narrowing things down a bit, I guess, what about for you? What is it that day to day or week to week, because I imagine no day is probably the same, but what does having this interest mean for your work and what you do?
So I'm looking at, I have, inverted commas, a portfolio career. So I work for Signet Health, which is an inpatient tier 4 eating disorder service. So it's a 14-bedded unit. I do that around 3.5 days a week. And then a day and a half I work at the Nightingale Hospital in London. So that's a private clinic. And then on top of that, I do the sports stuff, like I mentioned before. But what is really useful for me is I get to see different types of presentations, and I see people at different spectrums. The best example I can give of that is today we've been talking so far about the benefits of physical activity. And for 99% of the population, it's really helpful, and we're always going to advocate for that. Small percentage wise, there are some people who have exercise addiction, or orthorexia as we call it, this obsession with being healthy. So I often see that different spectrum as well, often on the inpatient wards, and also I work in sport. So I'll also see a different type of illness where actually sport and performance is functional, it's somebody's occupation, but it can turn into something else. It can turn into exercise addiction or performance problems, or we may call it relative energy deficiency in sport. So I'm quite lucky that I see different aspects of the spectrum when it comes to mental well-being through to severe mental illness. So my work is a combination of inpatient outpatient community site work as well. And that for me is really helpful. And for example, in clinic, that's when I tend to work with athletes. So more of a kind of outpatient basis.
Could you tell us more about what that 1%, that kind of exercise addiction, or when it sounds like maybe sports isn't a good idea?
So like I said, for most people, recreational sport, it's biopsychosocial. We know the overwhelming benefits of that. If somebody's using sport or exercise as their sole way of coping, this is really embedded into somebody's identity. This is how they use exercise has been used to cope with distress or kind of mood regulation. We know that things can get a bit obsessional with exercise then, and we're going away from healthy exercise to kind of problematic exercise. And when I'm saying problematic exercise, I'm going running every day and I'm getting localized external injuries. So I'm getting a Achilles tendonitis, I'm getting knee injuries, etc. And also there's just more compulsive type behaviors. So I have to exercise, or I'm going to do my activity and, like forgo a social activity or a social plans. And then when we're talking about exercise addiction, we're talking about internalized problems. So we're talking about hormonal changes, osteopenia, so thinning of bones, stress fractures, compromised immune function. And somebody become really rigid about their exercise. They can't not do the exercise. Their exercises when they're injured, they're very guilty if they can't exercise or train. So that's what we'd call a primary exercise addiction. So that's not associated with any disordered eating. If somebody has an eating disorder and an exercise addiction, we'd call that secondary exercise addiction. And we know that that's more severe. And especially if you're thinking about an eating disorder, we know the prognosis is a lot worse if we have that alongside an exercise addiction. It's almost like a more severe form of illness. So that's what I sometimes see. I guess the good thing is in sport, you'll often, if you're in professional sport, you'll have a team around you, and it's quite easy to get clinicians set up and to provide that early support. What I do often worry about is almost like the weekend warriors, the people who are just, I'd say like you and I, general public, I like sport and are over-exercising because they don't have that support, they don't have that education around them. And this word I mentioned before, this orthorexia, this obsession with being healthy, looking for this perfect exercise regime, looking for this perfect diet, and the anxiety that's associated with it when you're not able to do the exercise or have the right meal plan. I often see them in clinic, and sometimes they can get quite unwell, and it's been missed because they don't have that accountability, they don't have that team around them.
And potentially it's something that is easy to cover to friends and family to an extent, because you just say that you're being healthy or you're looking after yourself, or it's only exercise, what's the problem? Spot
on. Yeah, it's exactly that. And it is quite insidious because to start off with, you're getting positive comments from peers, you're getting that validation. And again, think about that spectrum again. At some stage, it was healthy. It was really helpful for somebody. But I just remember some of the male patients I've worked with, they'll say, look, when I was at my most ill, that's when I got the most positive comments. And that's when I was the most convincing. I had every reason as to why I was taking this supplement or that supplement or doing this type of exercise regime. And it's only afterwards when they look back and say, well, I really needed some support. So there is something about how do you access that support? How do you give that to somebody sensitively? Because you will upset people if you challenge that and you say, well, actually, I am a bit concerned about your current activity.
It sounds like there are things that are very similar in the way that you describe the way that people are thinking at those points. Something that can be very similar to what people who are experiencing an eating disorder, or maybe even something like an obsessive compulsive disorder, like where you have this compulsion to do something, you get extreme amounts of anxiety if you can't do it, and that belief is held so rigidly and it's so unshakable. Is there a lot of overlap, or are there things that are actually quite different?
No, I think that's in line with the evidence base as well. We know that there's a huge overlap between eating disorders and OCD. I think a 60% overlap from a recent study this year. So we know there's a huge overlap with this. And we know that if you treat somebody with comorbid eating disorders and OCD, if you treat one, the other one can get better as well. So it's really important that when we do that formulation, and we're really getting to understand somebody's problem, like you've identified, we have to recognise any comorbidity and how to manage that as well.
And what would the work that you do with someone who is coming with these kinds of problems look like? How, once they've perhaps approached you or somebody close to them has suggested that it might be good that they speak to someone, how would you approach working with them?
I think it has to be led by their narrative. We have to be guided by the patient or the service user in terms of what they're describing. Sometimes somebody may come in and they may engage with disordered behaviours, but they are in inverted commas healthy. And I think from my perspective, just to add, I think a psychiatrist working in sport, you may be involved with performance sides and health and all kind of thing. From my perspective, I purely work on health. So my priority is always going to be medical stability and the health. So the first thing that I'm thinking of when somebody comes in clinic, how safe is this person? But that's looking at, are they hemodynamically stable? Do we have up-to-date bloods? What is this person's BMI, etc.? How are they doing performance-wise? So I think that will always be my message. So if there's any concerns in that regard, I have to challenge that. If somebody is otherwise stable or healthy, then sometimes it isn't the right time to say, look, we're going to have to recommend restrictions. Because again, once they leave clinic, they are entitled to do what they want to do. But then if we're talking about somebody, and I have done this before, if somebody's severely unwell and they're in elite sport, we have to say, look, we're going to have to put some boundaries in place. There's a really good tool. It's called the REDS CAP tool. So that's Relative Energy Deficiency in Sport, Clinical Assessment Tool. So if you just Google that, it's free to download. And that's quite helpful because the example that we're talking about, it involves an MDT. So if somebody's come in with exercise addiction or eating disorders and they work in sport, you have this framework. So it's almost like a contract which the athlete or the patient has to agree to. And it's giving you the recommendations from the dietitian, the psychiatrist, the sports clinician, and saying you have to maintain this weight range, you have to be engaging with therapy sessions, etc. And if any of those are compromised, we then say, look, based on this contract, you are not allowed to compete in this competition or exercise X amount of times. And that, again, can be quite helpful because we're all being transparent and we're creating that accountability. But I think that's often the best way of working. There's another tool by the IOC, so the International Olympic Commission, which talks about in a very kind of rag rating type way, what's a red flag to say, look, somebody cannot compete in sport, what's amber, what's green. And that can be quite helpful as well, running through that with an athlete in clinic to say, look, this is where we're at the moment, and this is how we're going to get you back into sport.
So I guess that brings us on to think about, in terms of elite sport and the kinds of issues that you might be working with there. And I guess this is something that's come into the public sphere a lot more in recent years. Like when I was, really starting to think about meeting with you, all these stories from the past came in. I think like Simone Biles with the American gymnastics team, I think in tennis, in football, athletes are starting to publicly speak about what difficulties they may have had with their health, be it mental and physical. What it is, has that sort of coincided with the explosion of this field that you've seen through your career? How has all this come about, do you think?
Yeah, I think that there is certainly more awareness, and I think athletes in the last few years are more vocal about their difficulties. And that, from my perspective, is certainly a positive thing because we know how difficult it can be to navigate through sport, whether that's getting into sport, elite sport, the performance challenges of competing at this level, but also that transition out. So once people, whether that's planned retirement or kind of forced because of injury, deselection, these types of things. So it is really difficult. And I think there is something really powerful about an athlete speaking about their challenges because it is more like relatable for the general public. The best example I can give is, say, Freddie Flintoff and disordered eating. When that documentary came out, I think that was really powerful for men who may have struggled with these types of illnesses. So I certainly think the type of work that I do has coincided with athletes speaking about some of their struggles. And I know I keep referring to my book. I promise I'm not trying to sell it. But that was the example that we had, an athlete being able to directly provide that narrative of this is what I experienced or this is what we tend to see. It can be really useful for us as clinicians to take a step back and say, well, this is what we know, this is what we don't know, this is how we need to improve things.
You mentioned there's maybe different areas in which people can work in a sports psychiatrist, or that the work of the field of sports psychology, psychiatry, can be thinking from a performance side and then also from a health side. I know we'll probably be speaking more from a health side today, but would you give us a sense of what the performance side means as well, or what that might involve?
The best example I can give is from an eating disorder perspective, because I think that's been my main area of expertise. So a common thing that I may get in clinic is I've got an athlete, they're struggling with performance, so they're not able to train as well, or their times are slipping, for example. There's a query of kind of RED-S. So RED-S is relative energy deficiency in sport. Essentially, it just means there's a misbalance somewhere. So the intake is not matching expenditure, or vice versa. Now, sometimes it can be very innocent. It's just, you know what, I've got my training plan wrong. I'm doing too much exercise and my intake is not sufficient. And we can rectify that quite easily. Speak to a dietitian, and that's resolved. The red flag, and one thing that I always say is to any clinician, never diagnose REDs if we haven't assessed for an eating disorder, because then we're labeling something as a kind of inverted commas, quite trivial, it's easy to fix, but actually it can have severe consequences, especially if that's being driven by an eating disorder. Now, why that's relevant to performance is what we know is that if somebody has been in RED-S, in REDs for a sufficient amount of time, some studies say you've got about 8 to 12 weeks of a window of opportunity where somebody can maintain their performance despite being in relative malnutrition. And then after that, it starts to drop off. So from an eating disorder perspective, in that situation, that's almost the motivator to say, look at your performance. I've done this in clinic. Let's go through your times over the last 3 months. Why is this dropping off? This is the buy-in to get you back into sport. We need to address the malnutrition. We need to address disordered eating or over-exercising. So that's quite nice to bring in as an example for performance. Where I think a psychiatrist can be really helpful in this situation is if we think about our training, we become experts in assessment, diagnosis, management, and especially differential diagnosis. Now, somebody might come in with RED-S and performance problems, but they're also going to be coming in with very similar symptoms of overtraining syndrome or major depressive disorder. Now, these types of things is where somebody is struggling with energy, struggling with motivation. And that's when you need that kind of expertise to say, well, look, actually, this is disordered eating. This is how we rectify it. Or is this low mood? Is this more than just a simple energy deficiency? So I think there's a huge overlap between mental health versus performance. Mm. If I see somebody in clinic who there isn't a psychiatric illness or there isn't a medical issue, I would then say, look, these are my colleagues who work in performance psychology. This is their expertise. And I think, again, that's the benefit of psychiatry training, because we're used to learning and training within an MDT setting. We have a team around us, and often we're in that leadership capacity as well.
Mm. And aware of people who are not in the clinical world, but MDT being a multidisciplinary team. So like you say, having that expertise from people who've come from different backgrounds and different training. How do you... And this is me perhaps being cheeky, but one of the things that I love about this is really getting a sense of what people's clinical practice is like. How do you ask these kinds of things? How do you get someone on board in the consultation with questions that are, I guess, what kind of questions do you ask to make sure that you don't put it down to something really simple and forget to think about something actually that needs more input, more thinking about?
I think the way I approach taking a psychiatric history, if we think about the typical templates that we have, where I tend to start actually is social history, because you really need to get to understand somebody first. You need to know the context of the sport, what's the function, what's their identity. So I find that's quite helpful. And then again, it has to be the patient narrative. There's no point in me asking questions. So actually start off with, I leave it quite open to say, look, tell me from your perspective what's going on. Why did your coach ask for you to see me today? What have you noticed? What's your aims of this consultation? So I leave it quite open to start off with. But then at some stage, we do have to do rating scales, so we have to be objective. I'm not saying this works every time. There are times where it's actually, I haven't provided a helpful consultation, and that's me being fully transparent. Because for some people, they just feel, you know what, things are fine, and I've got to respect that. But I do think that it is important to be led by the patient's narrative.
How does your own experience of being in sport, I know that you said that that was a really big part of your life growing up and later as well. How does that feed into the way that you work with elite sports people?
I think if we just think of any type of specialty in psychiatry, so whether that's perinatal, substance misuse, older adults, whatever area you specialize in, you've got to understand the culture. You've got to know the lingo. You've got to know the stigma. You've got to know the barriers. You've got to be able to really understand that. Growing up, I did some sport at decent levels. I did county, did national at some stage. So I'm used to that setup. And I've also got colleagues who progressed much further than me and, did professional things. And speaking to these types of people, you know the challenges that they went through. And you also know how brutal sport can be. So I think that certainly benefited me because I was able to understand the context a bit better. So I think there is something about just knowing the culture. So from my perspective, it's purely recreational. I've just enjoyed sport. It was never that other side, but that's certainly been useful for me.
I guess going back to the way that you'll be working with people in elite sport, what are the kinds of difficulties that you have when I guess there are these competing interests from the people who might be referring this person to you or from the people who might be recommending that this person comes to speak to you? I guess everyone's interest being in their performance or in them getting better in time for the next competition or things like that. How do you think about that? How do you work with that?
So that's, again, what's been helpful because I have the boundary of I'm health, not performance. And also I'm a separate entity. So there's a lot of different setups. Some sports psychiatrists may be embedded within the team. Some may be an external entity. And so far, on the whole, I've been an external entity. So people coming to see me know that I don't have an influence on coaching decisions. I'm not there to comment on performance, so to speak. I'm not going to be looking at metrics and saying, look, based on this, you can't compete. I'm purely looking at it from a health perspective. And I think that can be really powerful, and everything's confidential. And if I am going to breach confidentiality or saying, who would you like me to share this to? And more often than not, they're happy for it to be shared. I know some psychiatrists, especially in the US or Canada, they're directly embedded in teams as well. And I think there's pros and cons to kind of both situations.
Because I always wonder about that when, I don't know, you're watching the World Cup and from like a physical injury perspective, you wonder how is, the physio that's running on the pitch or the medic that's running on when the person is so desperate to get back on and get back to competing, where do you find almost the strength to say, no, this is a danger to your health. This is a problem, and the disappointment that, I don't know, I guess as psychiatrists, to an extent, we often tell people things that they maybe don't want to hear. But this feels like a whole other level when it's everything about the person's life and everything that they've put so much work into.
And I think we certainly have to be sensitive, have empathy, but also we've got a duty of care. We've got to think about somebody's safety, somebody's health. A good example would be, say, a concussion in sport. That's been quite contentious, but you've got medics coming on the pitch. They're solely there to protect somebody's health and also their risks of neurocognitive problems or further problems down the line. So we've got to be boundaried. But yeah, it can be difficult at times. But again, having that separate entity, even if you are embedded in the sport, if your pure line of work is duty of care, that can make sure that we can just focus on what the task is. Has the issue of concussion in sport entered the work that you do? So I'm training older adult services. So I do provide memory assessments. I can do neurocognitive type assessments. If somebody's had memory problems or neurocognitive problems, they can see like neurology. We have what we call the SCAT5. So that's something that's been used in sport, which assesses for cognitive problems after a head injury or a head collision. And a lot of those symptoms mirror kind of anxiety, depression, often what we see when somebody's coming back from concussion. So again, it's been able to do that assessment. In all honesty, I don't do many of these. It's kind of covered within the sport already. The sports medics are very good at that. But again, if somebody's then 2 weeks, a month down the line still having these types of problems, they may then say, look, we need to see a sports psychiatrist to provide kind of input in that as well.
And I wonder if we've dotted around this a little bit, but would you speak a bit to the range of things that I guess you discussed in your book, but also the range of mental illness or psychiatric problems that people in elite sport might come to you with, or the kinds of things that you might work with?
On a personal level, I think because of my background, majority is eating disorders or disordered eating. But I often see, and this is similar to what general sports psychiatrists will work with, is depression, anxiety, performance type challenges may co-present with that. So that's typically what we'd see. But just from the prevalent studies as well, we know that eating disorders are certainly more prevalent in the elite athlete population compared to the general population. And if we think of low mood, anxiety, that can be similar to the general population as well. ADHD is a really contentious one, because if you think about ADHD, you can use sport and exercise as a positive, as an outlet for ADHD symptoms. Whether it's more or less prevalent in sport, the jury's still out, so it's a bit of a grey area. But I have worked with athletes before who've got ADHD, and I've been asked to provide a psychiatric opinion on that, and then thinking about what we call therapeutic use exemptions. If somebody needs to take ADHD stimulant medication, is that justified because of ADHD? That's just a snapshot of the commonest things that I see. If somebody wants to learn more about this area, like I mentioned at the start, the IOC, we have these consensus papers from around 2018, 2019, and that gives you a really nice overview of the different things that we tend to see in sport. What we don't tend to see is what a kind of bread and butter psychiatrist would say, which is psychosis or schizophrenia or these types of things. If you think about just the nature of sport, I think it might be quite difficult for somebody to be competing at that level, especially think about negative symptoms. So from my understanding, the evidence on psychosis or bipolar in sport is less strong, but whether that's there, I don't know. But hopefully over time, as we get more access to athlete data and be able to do more studies, we can be more confident, when we're talking about the different types of conditions that we see.
I'd love to know more about how you approach treatment, because that sounds like, again, the challenges and the personalization of it is quite different potentially to someone who isn't working at an elite sports level. Could you tell us more? I know you said you might start with therapy. Is there a particular kind of work that you might be pointing people towards doing, or even as far as modalities go, or how do you work with it?
I think from what I've experienced the last couple of years, cognitive behavior therapy is really helpful because it's very here and now, and it works quite well for the athlete mindset of, I've got a problem, how do I sort it? That can be quite useful if you're thinking about an athlete's commitments, if they're touring, matches, performance training, etc. But you have to be quite flexible with it. So somebody who doesn't work in sport, you may say, look, 20 sessions, going to meet at this time every week, and that's really important. For athletes, it's very hard to do that. But from my experience, CBT can be quite powerful in that way. And if you think about just the sports dynamic and the environment, sometimes kind of systemic therapy can be quite useful. I'm not an expert in that area, so I will always recommend colleagues who can provide that. But again, it's that multidisciplinary approach. We're all working together to support the athlete. So that's always been my approach. And then from the start, if somebody is presenting more distressed or more severely unwell, I think being fully transparent with medication. I'll never see somebody prescribe medication straight away. I'll always say, look, this is information, this is the leaflets, let's catch up again. So they've had a chance to read it and say, look, these are my concerns, or this is where it may be helpful. And then once somebody's come back and gone through that, we can then discuss it and say, look, based on the current challenges that you're experiencing, this is what we'd recommend. I guess we've not really delved into it so far, but that's the privilege of being a sports psychiatrist, understanding pharmacology, knowing what the pros are of medication, but equally very much so what the risks are, because athletes can be more sensitive to medications. And there's also going to be a lot of I don't want to take it. And you can see why if you're in this kind of environment, but equally we have to challenge that. If somebody has a severe mental illness, they need treatment for that. And obviously we'll always follow a phased approach. We'll always say, look, let's try therapy first. Let's go through lifestyle interventions. But again, lifestyle interventions for them may not apply as much because they're already doing a lot of sport or activity, because they're not doing sport for health. They're doing this for function and performance. And if we've gone through that, despite if somebody's struggling, I think we should offer medication, because then we're not offering something that has an evidence base that can be helpful for somebody. And my perspective is to always do the 4 to 6 weeks of, it's almost like an algorithmic response, which I learned from Professor Alan Curry, who's like a mentor in sports psychiatry. And he's had this approach where we should have a really low threshold to review medication. So if within 2 to 4 weeks it's not helping somebody, we have to make a change, because we know from the evidence base that it's going to improve in terms of outcomes for somebody. So yeah, it's a regular review, being mindful of side effects, and again, performance is a huge part of this. So we wouldn't recommend medication that is going to cause oversedation, weight gain, or these types of things. It's very much a kind of, what's the safest medication for this person? What's their function? What's their sport?
That sounds so difficult, because that's issues with so many of the medications that we use. And then that's not even counting the fact that some people will react to something in a slightly unpredictable way, something that's not meant to be sedative. Someone might well find for them is.
And that's why, again, it's the same principles of general psychiatry, start low, go slow. We have to do it step by step, and we have to be guided by, the athletes on that, seeing how they find it. I always say, especially if we start a new medication, the first 3 to 5 days, it's not a write-off, but it's going to be a difficult time. You may get some nausea, you may feel tired. So we've got to be very, again, step by step, walk somebody through it. So this is what we're expecting, but this will get better. And in most cases, 9 out of 10, it will get better. But obviously, if this isn't improving for somebody, we have to review things straight away and come up with a different plan for them.
And I wonder, you potentially might have quite unique experience in terms of also taking people off medication once things are better, because I imagine in the sports world, people might want to stop as quickly as they can. How is that something that you've worked with or noticed, and what is that like?
I guess we've got to be guided by an evidence base, and if we're thinking of extrapolating evidence for sport, often it is guided by the general adult population. And if we're thinking about examples of depression, anxiety, we know with antidepressants it's that 6 to 9 month period of stability, and then we assess it again. So I still follow those same principles. And I've actually, with some of the athletes that I've worked with who are at this stage still high performing, very much top of their game, they're still on medications that we've prescribed because they've got used to it. It's given that stability. And that's after we've done that 6-month review. But we will still assess again and say, look, let's see where things are at. Are we at a stage where we've got relative stability, and should we start reducing medication? So I wouldn't necessarily stop medication sooner for somebody if we've suddenly got the stability and they're performing well and things are stable. And that's an example of a challenge that we have, because we're not using athlete-specific evidence or data, but we are extrapolating from the kind of general adult type evidence.
What would you want to see in the evidence base that there isn't yet for the elite athletes?
Well, I think being guided, if we're thinking about valid studies from a representative cohort of the changes that we're making. So I think that's extremely difficult. Even if we think about numbers, it'd be very hard to capture those numbers. But if we do get access to more data, and I think there's a lot of efforts. There's a new journal called Journal of Sports Psychiatry, and that's specific to sports psychiatry topics. And if reading these publications, we're seeing more evidence coming out. So I think it is an exciting space if over time you can meet an athlete in clinic and say, well, actually, we know we've got a better understanding of these situations. We know at what point we should prescribe, at what point we shouldn't, at what point we should be phasing off. And I think that would be a really powerful situation to be in.
From the psychological treatment perspective, because I understand that you're somebody who's also trained in CBT, particularly in the sports and exercise world. Correct me if I've got that wrong.
So I'm trained in CBTE, so more from the eating disorders perspective. So I'll always offer that if I'm seeing somebody in clinic. In terms of the basics of motivational interviewing, behavioural activation, I'll do that with all patients regardless, because like I said, I think it's really powerful to be able to offer that as a clinician. But as soon as I feel actually you need an expert, I know somebody who's really good at that, we'll again set up that team approach. We'll get that team around the patient or the athlete.
And what kind of, I guess, thinking patterns might you be, if somebody was asking you, what is it that they're going to do? Like how are they going to work with me? What kind of things from that person's own experience that they've brought might you explain to them that is going to be looked at?
A really powerful one I often find is athlete identity. And I really saw that during COVID. And in all honesty, that's when I got quite busy because people were really struggling during that period. Because if you've invested a lot of your identity and your time and efforts purely on your sport, and we'd often do this pie chart where I get people to draw out the percentage of time they spend doing things. And what was quite fascinating was during COVID, people realized I invest so much time in this and it doesn't take much, like we saw, for things to suddenly stop. And people got quite reflective. And there was a few who actually left sport, not elite sport. This is more, again, semi-professional or just somebody who did it like that weekend warrior scenario that I described, just very into sport. And when they was looking at these pie charts and saying, look, 60-70% of my identity is focused on sport, I've got a problem here, I find that quite helpful. And often when it comes to sport, it's the narrative that they provide to their identity. So is this a performance type metric? So am I saying this because I need to be the best, I need to win, I need to compete in this tournament? Or is it more purpose-based? Is it because I just love the sport? Or, what's my purpose behind that? And I find that's quite powerful for athletes. The other thing to challenge is kind of all or nothing approach. And I think we're all at risk of doing that at times. But often in sport, you'll often see that all or nothing type dynamic. So I have to win that event, I have to get a PB. So again, it's sensitively challenging that and, what ifs and what's the alternatives? And also working through that together and being able to write it out and draw it out, I think is quite powerful. And I think that's why the CBT model and the CBT formulation and the different stages we go through with CBT and that modular approach, I think is really helpful.
I'd love to know, because yes, I imagine that all or nothing approach might feel for people like that is the way to achieve. They've got to aim for gold because that's what's going to motivate them. That's what's going to drive them forward. And the fear of failure or the ways that they might beat themselves up if they get anything at less is the stick again that kind of keeps them going. What can we all generally maybe learn about failure from the work that you do with elite athletes? But also, how is that truly the way that it has to be, or do you find that people can get more out of themselves with a different way?
It's going to sound a bit cliche, but moderation is key. With all these types of things, how do you find that perfect moderation between these things? Because actually, again, as an athlete, being very rigid with your exercise routine, very prescribed about calorie intake for an athlete in training or in competition, that's actually functional. It's really helpful. I guess the message here is a lot of these things have to be time limited. We need to have clear boundaries as to when we apply these approaches and when we don't. If you're not competing, if you're not in season, why are we still following these ways of working? And again, how many of us are elite athletes? So it's a very small percentage of society. And that's what I'll tell people in clinic. If I'm seeing somebody with primary exercise addiction or orthorexia, it's really kind of debunking, do we really need to know how many calories we're having a day or expenditure, these types of things? That's the message there. So if I'm seeing somebody in clinic and we're talking about all or nothing, like you've rightly identified, sometimes that can be helpful if it's a focused task and we're working towards something. But if we're not doing that, do we still have to have that approach? A really good example I give is the Yerkes-Dodson curve. So if we think about anxiety and performance, so we know that a bit of anxiety and cortisol is actually really good for performance. But the problem is if we're constantly anxious and really high anxiety, we know that will affect performance. So again, it's that example of moderation, being able to manage these things. And if it's something, again, going back to the anxiety example, if this is ongoing and we're not in sport, we're not competing, it's not a pre-race, then we've got a challenge here and we need to support somebody with that. So I think it's, just getting timings right and also moderation. But it's very easy for us to say that because we know it's never that straightforward.
No, it's not, but it's, that idea of moderation, just getting a balance in everything that you think about and how you think about it, seems to be such a prevalent and helpful thing if people can get their teeth really sunk into it and can kind of come back to that whenever they're feeling some kind of difficulty. Am I thinking about this, I guess, in the most moderate way possible? Have I got the right balance? That's really stuck with me. I think I want to take that forward. I know we've talked a fair amount around your eating disorders interest and the work there, but I wonder if we've really only just started to scratch the surface. What are you interested in this area at the moment, both in relation to sport, but perhaps more for general adults? Where is your work there?
I became a consultant in 2020, so I'd like to think I'm still quite new. I'm still learning. But when I started my eating disorder post, a lot of it was the COVID demographic. It was young adults during that transition of 16 to 18. We're supposed to be going to uni. We're supposed to be doing exams. So we saw a new demographic of people with an eating disorder. What I found in my experience over the last year or so is much more comorbidity, or maybe that's how it always was, but because I started new as a consultant, I didn't see that. So now I'm seeing a lot more ASD. So comorbidities, just to be very clear, that it's very common for people with an eating disorder to have a comorbidity. So about 50 to 95% of patients with an eating disorder will have a comorbidity. So whether that's low mood, anxiety, suicidal ideation, personality, challenges of personality disorder, and also neurodevelopmental conditions like autism. So I'm seeing much more of that in my practice. And how do we treat people and how do we manage everything? Because sometimes there is symptom substitution. We treat disordered eating, but then that may impact on low mood or self-harm, anxiety. So I think there is something about how do we as clinicians manage the whole thing. What I find quite helpful is DBT, so dialectical behavior therapy. Again, it's quite nice because it's very practical. It's very much daily diaries, reflecting on how things are going for somebody, but also very practical tools. So if I'm very emotionally distressed, how do I manage that in the moment? Some of the examples is, using cold water, intense exercise, pace breathing, muscle relaxation. That can be really powerful for an athlete who has very limited time to access support or who's traveling. But, with his apps these days, the jury's out on how useful apps are. But if somebody's got a very practical tool to help them, I think that could be really powerful.
Mm-hmm.
The other thing, just to answer your question, the other thing that I've always been interested in, and I've done some research in it, is looking at exercise addiction, especially in eating disorders, because it's really hard to treat. It's really hard to manage. So on an inpatient wards, sometimes people come into hospital under the Mental Health Act because they're very severely unwell. And the nature of exercise is so addictive, so compulsive, very hard to break the cycle, so to speak. And I've worked with particular athletes or people from an athlete background who were at a relatively low BMI. So if we think about females who may be below BMI 15, not having regular menstrual cycles, impaired bone health, and compulsively exercising. So we've had to be quite restrictive, fully transparent, and said, look, we think you're really struggling. We're going to put you on one-to-one nursing observation. So a nurse is going to sit with you for 24 hours a day. We may have to lock your bathroom because we know that can be difficult for you when you go in and exercise. And we broke a cycle for somebody. They managed to move away from exercise being isolating and compulsive, and we've introduced them to a group program. So it might be a group run, it might be Pilates, yoga, swimming, and just changing that relationship with exercise. So I think I've always found that really interesting. There are some case studies of medications like high-dose sertraline, quetiapine being helpful for exercise addiction, but the evidence base isn't that strong. But again, the beauty of working on an inpatient eating disorder ward is we've got a pretty good team. We've got a nice team around us. So a dietitian, psychologist, occupational therapist, physio, get the full gambit. And I think that can be really powerful if we're thinking about how to manage exercise addiction. We don't always get it right, but the cases that we do, it's a really good feeling as a clinician because you've helped somebody not only manage an eating disorder but exercise addiction. So I think those are my interests: exercise addiction and eating disorders, and comorbidities that present with eating disorders.
Curious about what you've talked about, the benefit of group, and I guess it's just got me thinking about just the benefit of group sport that we see in general, but also group treatment that we have, group therapy, group analysis. Have you seen, and I guess DBT does DBT involve group work?
That's right, yeah.
As well. That seems like a bit of a theme. What do you notice comes out for people if you can get them less isolated in their exercise addiction or with their eating disorder?
Just on a general level, I suppose I mentioned at the start biopsychosocial, and we were talking about benefits of exercise. if we think about biopsychosocial tool of exercise, the biological is we're going to talk about BDNF, brain-derived neurotrophic factor, endocannabinoids, all these kind of physiological mechanisms that we're still understanding. But the psychosocial makes a lot more sense if we're thinking about self-mastery, self-esteem, distraction techniques. But that social element is really powerful. And what we also find from the studies is that there's 2 studies that were done, I think they were by Philippe Schuck, who's a Brazilian researcher. But what he found was that for general adults, they actually like personal training. They like having one-to-one support for exercise. But what was fascinating was in older adults, they prefer the group connection. They like being in that group, being able to exercise, together. So I think there is something really powerful about the group setting, being around people who are also struggling from the same illness, but also benefiting from the same type of thing. So thinking about group exercise, I think, can be really helpful.
Amit, thank you so much for speaking to us. As we, I guess, come towards the end, I wonder what, as you've said, you're in your early years of your consultant career, and you've pointed towards some of the things that you're interested in looking forward to. But what are the next couple of years looking like for you? What are you excited about in the field of sports and exercise medicine and psychiatry? Where is your attention going to be going?
It's split between those 2 things. It's literally really promoting, and I don't want to say exercise, lifestyle interventions. It's an exciting space, and that I know that there's more awareness of nutritional psychiatry. Again, still learning. I know in Australia that's quite a strong field, and that's developing. What really excites me is when we have our SPEPsych meetings, we meet twice a year, and their energy and passion in the room, and it tends to be from the trainees to say, look, we're really keen to promote this and use exercise as a therapeutic tool. So that really excites me. And as somebody who started doing parkrun again, I can see the benefits. So how do we translate that and bring that into mental health services? I'd love for us to be able to do that. So that excites me. And also on the flip side, elite athlete mental health, seeing the development of support for athletes is really exciting. And also seeing that stigma is being removed, because I think the conventional view was athletes have to be resilient, they're supernatural, they don't get ill, they don't get physically or mentally ill. But we know from the evidence that's simply not the case. So it is about how do you provide tailored support for athletes. And I don't think we're there yet in terms of tailored, but hopefully over time we'll get better at that so we can get better at supporting athletes.
And if people want to hear more from you or look out for what you're up to, where would you send people?
So on a personal level, I've got Twitter, LinkedIn, Instagram, the usual stuff. So that's at Dr. D Mistry Psych. And then if you want to hear more about what we do as a specialist group, that's on Twitter. So that's RCPsych_sepsig, so SEPSIG. And also on the Royal College of Psychiatrists website, there's a special interest group section. And if you click on that for sport and exercise psychiatry, you'll see all our events, our resources that we have on there as well. And yeah, if anybody's got any questions or is keen to get involved, just drop me a line.
Thank you so much for sharing your time and your expertise and your energy for this field with us. It's been really wonderful to meet you and hear from you.
Excellent. Cheers for your time, Anya.
Thanks so much for listening this week. If you've got any feedback, as always, do get in touch. If you enjoyed the episode, why not give us a rating on Spotify or Apple Podcasts, because it really helps other people to find us. If you want to get in touch, you can find us on Instagram or Twitter, or you can drop us an email. And if you value the show more generally, why not buy us a coffee just to help keep us going? Thanks so much.